All right. Well, I've got 1 p.m., so we'll go ahead and get things started. Good afternoon. Today is February 18th, 2026, and we are here for our weekly measles media briefing. I'm Casey White, a public information officer with the South Carolina Department of Public Health. We'll be joined by Dr. Linda Bell, state epidemiologist, who will provide an update on the measles outbreak in the upstate. And following her presentation, she'll take questions from reporters. Without further ado, I'll turn things over to Dr. Bell.
Thank you, Casey, and good afternoon, everyone. On Tuesday, the South Carolina Department of Public Health reported 12 new cases of measles in the state since Friday. That brings the total number of cases in South Carolina related to the upstate outbreak to 962. There are currently 127 people in quarantine and 8 in isolation. The latest end of quarantine for these is March 11th. From the new cases, DPH has identified exposures at Libertas Academy, and there are 17 people in quarantine from the school. Additionally, fewer than 5 people remain in quarantine from Inman Intermediate. A new public exposure site has been identified in addition to the 3 announced on Friday. And for more information on those public exposure sites, you can visit our measles outbreak webpage. That page is updated as locations with known exposure timeframes are identified. The outbreak remains centered in Spartanburg County with 913 of the 962 cases located there. And of our 933 outbreak-related cases whose vaccination status is known, about 95% of them are unvaccinated. And again, no vaccine offers 100% protection against infection, but the MMR vaccine is safe, and it is one of the most effective vaccines in preventing infection. It has been shown to provide lifelong protection against measles for about 97% of people who complete the recommended 2-dose series. And while complications are not reported to DPH, or they're not reportable to DPH, but we do learn about them. And we have learned of at least 20 hospitalizations for measles complications, including encephalitis and pneumonia since the beginning of the outbreak. These hospitalizations involve both adults and children, and additional cases required medical care for measles but were not hospitalized. The measles vaccine is the best way to protect against additional complications from measles infections and to prevent ongoing spread. We are seeing a hopeful sign with the decrease in the number of cases reported daily this past week and just a few days prior to that. We believe that the stronger uptake of MMR vaccination last month is contributing to that decline. And if that uptake continues, we can reduce the possibility of another surge in cases as occurred after the holidays, or the introduction of cases into new areas. But filling the gap in population coverage from where we started is needed to end this outbreak. And as a reminder, the MMR vaccine is widely available at many primary care providers' offices, at pharmacies, at DPH health department clinics. Also, many children can receive vaccines at no cost to the family through the Vaccines for Children program or through their health insurance coverage. DPH will once again activate its mobile health unit to offer the MMR vaccination to the public at no cost on Tuesday, March the 3rd from 10 a.m. to 2 p.m. at Grace Community Church. That's at 570 Magnolia Street in Spartanburg. And with that update, I will now turn it over to questions.
Thank you, Dr. Bell. Most of you know the routine, but if you don't mind raising your virtual hand, I will call on you in the order in which you raise your hand. And again, if you don't mind asking one question at a time, we will cycle through our questions, and you're all welcome to raise your hand again, but just want to give everyone a chance to ask their question. We'll start things off with Maria.
Hi, Dr. Bell. Thanks for taking my question. So the vast majority of cases in this outbreak have been in school-aged children, 5 to 17. Can we talk about what we know about the beginnings of this outbreak and what the spread looked like in terms of, like, did it start within a family? Did it spread family to, among family members? And then how much of that resulted in transmission in schools? Do we have a good sense of that at this point?
So I apologize. The beginning of your question, I did not hear. I think you said that the majority of cases are among children. Is that right? And you want to know about the transmission chains? I'm sorry, I couldn't hear all of your
Yes,
question.
correct. That is correct. Like the vast majority of transmission chains, like within families and within schools. Was it like siblings within a family and then spread through schools? Like, can we talk about that?
Yes, we don't know the original source of the outbreak. I think I heard that part, but a major contributor to spread has been household transmission. We have identified cases in schools, but we have not seen ongoing transmission in school settings because of compliance with the exclusion requirements for those who are susceptible, and selected other community settings like transmission where we know that exposures had occurred in some church settings. However, one of the major transmission modes has been within household settings.
Thank you, Dr. Bell. I don't see any other hands, so it looks like Maria has another question.
Hi, Dr. Bell. Sorry, I just wanted to just to clarify that. So we have seen cases in schools. But they're not ongoing chains, but was there some transmission in schools because there were exposures in schools?
Exposures occurred in schools. We have not identified ongoing transmission within school settings from student to student as a significant contributor. We have seen repeated introductions of cases in school settings. One of the major contributors to transmission has been within households.
Thank you, Dr. Bell. And since nobody else is raised, can I ask another question? And it's just, you said you're seeing hopeful signs with a decreased number of new cases reported daily. Is it too soon at this point to say this trajectory is finally slowing down?
We are seeing a slowing, but it is too soon for us to say when this will end. The concern is that we can see ongoing smoldering transmission that can be introduced into other communities. The measles virus can find susceptible people wherever, it doesn't observe county boundaries or anything of the kind. So the concern is that the outbreak may be slowing, but we have a significant gap in vaccination coverage to get up to the population protection that we need. And so the risk of ongoing transmission for an unknown period of time is still there.
Thank you, Dr. Bell. And we've got a few other hands raised now. So Julie.
Yeah, hi, Dr. Bell. Thanks for taking my question. This is Julie Steenhuisen at Reuters. So the question I have is, and during your last call last week, you were talking about 2 other counties within the state that also had cases where you couldn't trace the chain of transmission. Are you seeing onward transmission from those cases, or are you looking at potential exposures in other counties, linked to this outbreak that would suggest onward spread? Thanks.
We have not seen ongoing transmission from the cases identified in those other counties outside the Spartanburg area.
Thanks, Dr. Bell. And Tom?
Hey, Dr. Bell, Tom Corwin, Post and Courier. You mentioned an increased uptake, and I think we've seen that in the numbers you have from January. You also are doing the mobile units again, and I'm wondering if you are, maybe it's just even anecdotally, are seeing greater response to those mobile units.
We still have not seen a significant number of doses administered in any of our mobile health clinics. And so most of the uptake is through providers' offices, pharmacy chains, clinics, and unfortunately, that opportunity to bring those services into the community to people has not been, we have not seen the increase in doses administered in those units as we had hoped.
Okay, thank you.
Thank you. And Danielle?
Hi, Dr. Bell. Danielle with WYFF4 in Greenville, South Carolina. Thank you for taking my question. We have some concerns from viewers here, so hopefully you can add some clarification. we have some residents, they say they've had the vaccine 1957, 1958, 59, early on, and they got tested and found out that they were not immune to measles when they thought that they were. What do you recommend for them? And also, what's your message to those who may have gotten the vaccine early on in those 57, 58, 59, 1960 years?
I don't have the exact window of time when the vaccine that did not stimulate as strong as immune response as the currently available vaccine, that exact window. But what I would recommend is that rather than people getting tested, that they can go ahead and get vaccinated again if they received a vaccine in that late 1950s, early 1960s timeframe, and they have any question and they don't have records to document what type of vaccine they received. There's no harm in getting another vaccine that will very likely, if they've been previously vaccinated, stimulate a stronger immune response.
Thank you, Dr. Bell. And Danielle, just as a follow-up, I'm happy to provide you with our recommendations. I know Jane reached out earlier this morning, and I should have a response over to y'all pretty soon. And the next question is from Allison.
Hi, Dr. Bell. In some of your past briefings, you've talked about some of the challenges with exposures in healthcare facilities and providers. What's the current state of how well the healthcare community is being able to manage the outbreak and exposures at this point?
Well, we have seen some of our healthcare systems who have followed the recommendations from DPH that for people who are presenting with respiratory illness signs and symptoms, that they place a mask on those people, that they also remove them from waiting areas where they could potentially expose others and put them in an isolated area for evaluation. Those are measures that can prevent the exposures that we've seen in healthcare settings, and we are pleased to see that some of our healthcare systems have already reported that they are adopting those measures.
Thank you, Dr. Bell. And real quick, I'm going to read a question from the chat from Deirdre McPhillips from CNN. She said, has South Carolina been pulled into any additional investigation or analysis with the Pan American Health Organization or CDC to make determinations about transmission patterns that could affect elimination status?
We have not been pulled into any joint investigations with the Pan American Health Organization. We continue to work with the Centers for Disease Control and Prevention with the submission of our clinical specimens to be genotyped, and with reporting our surveillance data so that we can have full information that they report nationwide as to potential sites of exposure in other locations. And so we work on an ongoing basis with the Centers for Disease Control and Prevention's measles response team.
Thank you, Dr. Bell. And Baker?
Hey, it's Baker Maltsby with the Spartanburg Herald Journal. I don't know how many, maybe y'all will be able to provide information on how many more vaccinations have taken place, in the last 5 or 6 weeks. But based on earlier school data, there's still quite a few unvaccinated children in Spartanburg County. And far more unvaccinated kids than there have been cases. And so I guess what I'm wondering is how susceptible are people still, or how much of a concern is that? And then also, are the distribution of unvaccinated young people, are they kind of spread throughout the community, or do they seem to be clustered in groups, where there may be, potential group exposures? Like, are they clustered in churches, certain schools, certain communities, in ways that might accelerate transmission again if, under certain conditions?
We remain concerned about anyone who's susceptible by either not having had the MMR vaccine or immunity from natural infection. We don't have information about where specific people who are susceptible are located, whether they're clustered or whatnot. We have population level coverage at the county level. We know what the vaccination coverage is in schools at the beginning of the school year from our 45-day school report. We do not update the 45-day school report on a regular basis. But as you're aware, we're continuing to monitor the uptake in vaccination coverage for the population as a whole in Spartanburg County, in the upstate, and for the state, month by month compared to the same period in the previous year. So that's the kind of data that we're monitoring to see how much progress we're making in improving vaccination coverage. We don't know exactly where the susceptible people are, and that's why we continue to message, if you don't know what your vaccination status is, please consult with a healthcare provider. And we recommend that everybody be up to date with their MMR vaccination.
Thank you, Dr. Bell. And it looks like we've got another question from Allison at HealthBeat.
Following up on the question about PAHO and CDC, is there any update you can share on some of the advanced genomic testing that is being done at CDC on the South Carolina cases, and anything that might be pointing any clues as to where or how the virus may have entered the state of South Carolina?
We won't be able to find out from genotyping how the virus entered the state of South Carolina. We are unlikely to ever learn how the virus was introduced into South Carolina. What we know from the genotyping is that the pattern that they're seeing is the predominant pattern, the genotype that is circulating nationwide. Additional genotyping will be performed to sort of drill down a little bit at some subtyping. That information is not available yet, but it is only with the epidemiologic investigations where we interview cases to find out where they've been, where they may have been exposed based on our knowledge of known measles cases. So that's where we get the information of chains of transmission, potential sources of exposure. The genotyping is really a delayed, after the fact assessment of what's going on in a population as a whole, as compared to strains circulating in other parts of the world and other parts of the country. In South Carolina, the strains have not shown any difference from the predominant strain in the United States.
Thank you, Dr. Bell. Julie?
You touched on this, but I'd like to sort of clarify. So I'm an epidemiologist today. I was reading characterized the outbreak in South Carolina as slowing. Would you agree with that assessment? Is it slowing, or is that too optimistic? Thank you.
It does look like it's slowing because the number of cases that we're seeing reported daily as compared to previous periods, particularly the surge, that huge surge that we saw after the holidays, the number of cases being reported daily now is much lower, and that indicates a slowing. We are not out of the woods, though, and I don't want that to give people a sense of false security that this is over. We are likely to see ongoing transmission based on the people who remain in quarantine, who may incubate out, and we would not declare this outbreak over until 42 days, 2 incubation periods after the last case that we identify in South Carolina. And so we can anticipate that that will be for many more weeks at least.
Thank you. That's helpful.
Thank you, Dr. Bell. And I don't see any more hands up. I'll give folks a second or two to raise their hands if they have another question. And I don't see any new ones in the chat either. Well, with no new hands, I'd like to thank everyone for joining us today, and thank Dr. Bell for her time in leading this this media briefing. We are always happy to answer questions via email at media@dph.sc.gov if you have a question before our next briefing, and we'll issue our regular update on Friday. Until then, we'll hear from you then. All right, have a good one.
Thank you, everyone.